I just put up there was that I have flagged to our working group just how productive we have been, really to make people confident that we have achieved something worthwhile before we even started to discuss the patients. So we have already achieved many of our month 6 outputs and indeed some of the month 12. What is not on that slide, though, is the fact that before we even started, we surveyed everybody, so that when we wrote our initial application, it was really quite quick. We worked with a small group of people who had the time. So before we started moving forward through this, we surveyed everybody, and we had 61 responses, a third of whom were patients or patient advocates, 9 different countries. So we were able to prioritise what we thought we wanted to be addressing, and that's guiding us through as we select what to do in order to deliver to the really stringent requirements, but also deliver what we feel is going to be of most benefit to the patients.
Which is?
So we felt that the most important thing was to provide guidance where there was none, rather than to reinvent the wheel with more guidance. And in terms of topics, the topic that came screaming out as the most important one or two were bleeding and anemia, which for a condition where we've tended to focus on the vascular malformations, this was coming out rather differently. And then from the patients, the hereditary nature, obviously the lack of inability to find good informed care, but the family aspects. Some of the topics that came through were not those that we would have necessarily predicted 2 years ago. So it was a very, very helpful exercise, and I'll be sharing the exact details tomorrow in our working group. And then we have supposedly selected what we're doing in the next 6 months, but we'll be finalising that tomorrow.
Okay, so thank you.
Was there comments from the group? No?
We'll go from HHT, was there a comment?
Okay.
Okay, thank you. So now HTAD.
So HTAD, I think Julie has taken her train back because this is her birthday. So she had a good excuse. So she left Anaheim alone too. Okay. So what are the priorities for HTAD working groups? So she prepared some slides. Go ahead. So go ahead again. Okay. So the first was sharing of experience, the discussion of difficult clinical cases. As she said this morning, that was the meeting that we had before. Okay, so we said that we met as everybody. Then we had the feeling that the pathways were something important. And there is here the general chart. I went through this morning already with this general chart, and then go ahead. And for the piece of knowledge, we discussed what were the important questions that we were going to ask to the different experts in different countries to have the different answers in different languages. And that's a list that we came to, so that will be the piece of knowledge. The registries, there are 2 registries which are on their way. There is MAC registry, which is a Montalcino Aortic Consortium registry, international registry about heritable thoracic aortic disease, with a European part which is going to be centralized in Paris, and we are proposing in fact to all the centers in the RN. And there is ROPAC, which is a European Society of Cardiology registry about pregnancy in patients with thoracic aortic disease, and which is in the way of being run. It's not completely started yet, and we will use this to include the patient with pregnancy and thoracic aortic disease. So there are 2 registries with more than 1 center. The definition of clinical outcomes, we wanted to select also simple parameters for 1 disease. So the disease that was chosen was Marfan syndrome with FBN1 mutation. And the parameters that were proposed, but I said to you this morning that this is really difficult and more difficult than we anticipated. So that was the proposition. The number of patients screened, the number of patients with a final diagnosis, a number of patients under follow-up, and a number of patients with an aortic event, dissection and surgery, and number and outcome of pregnancy again. But you see, there are a lot of numbers, and I'm not sure that it's easy to get these numbers from all the centers, and it is based on the understanding that the effect of the ERN is actually the sum of the effect of the HCP, and not only the intersection between the activity of the HCP, which is the other way around. So I think if there is more patient screens, it's better. I think, but that's okay. That was the discussion. Recommendation. I'm not sure Ingrid was here. Yeah, excuse me, I didn't see you. So Ingrid is going to, I started as speaking about and writing a manuscript about ACTA 2 recommendation. You want to say a word about that?
Yeah, as was being said this morning already, it's a recommendation, so not really a guideline, because there's no proof yet. There's no not much literature on it. So we started to write some recommendation, and tomorrow I'd like to hear input from all of you on the draft that I made.
So this is what's the priority of the working group, to go this, and then the IT platform we said already. And that's it. So we have these priorities in the HTAD working group.
I haven't been organized enough to do slides or a chart like previous people have done. So essentially, one of the biggest things that we have done in our monthly conferences is that we focused on areas which we feel we can make a dent as a progress in. So the areas that we've been focusing on are the research clinical trial that I talked about earlier with that Xavier is involved in, and kind of seeing how we can actually incorporate that within our centers, because the number of vascular EDS patients is quite small anyway, and therefore kind of getting more patients from different centers might actually be much more appropriate. But we've been discussing that that might actually be slightly more difficult in terms of how we establish it in different countries, and whether we do a new proposal is something that we are actually talking about a bit further. So that's one thing that we have talked about. The next thing is about in terms of doing registries. Again, there is the Radico ECRF, which is already in position in with Xavier's group in France. So that we're going to have a discussion about that tomorrow. And so there is a process now for how it will be approved, and ethical approval will also happen, so that we can then start adding patients to the registry. Hopefully in the future, data from this can be used by all groups for studying further as well. So that's the second thing. The third thing is we talked about patient passports, because that's another way of patients having some information and being able to have this information with them when they present to a medical personnel, so that immediate attention or people who are experts in this condition can actually be contacted, so that that way information will be and advice will be given to whoever this patient presents to. So again, about standardizing that as much as we can, not reinventing the wheel. There are already 3 or 4 patient passports available. So kind of bringing it all together and empowering the patient with this information, so that that's helpful for them. So those were the 3 major points that we were looking at. I'm putting a little bit of focus on Jürgen for this. He is going to liaise with Valentina in terms of patient pathways, how they present and how they actually are then managed and diagnosed. So that's the next thing. So I think most important, as I've said earlier, is we have really enjoyed discussing cases, because often we are left in the situation where we do not know what to do with our patients. So we've used a lot of our time kind of focusing on that. So that's our progress. So it's certain things like pills of knowledge, availability of conferences on YouTube, all of that I have left with Alessandro Pini, and he will update us. And in terms of recommendation, we are looking at writing up pregnancy for vascular EDS, which again Alessandro is doing.
Okay, thank you. So a lot of activities. Oh, we can change. It's VASCA. Now it's VASCA.
Okay, very good. So a little bit like in the morning already, I mentioned our first activities have been focused on the orphanet classification, and we will hopefully finish that soon. And also then trying to get at least partly the vascular anomalies in the OCD-11 classification, because we feel that that's the basis for all our work. If we don't have that cleared, all the rest would be very complicated. And very tightly linked to that, it's what Leo is doing here in also the larger transversal group. It's a registry, to try to perhaps get retroactively something in a virtual database from at least some of the centers, and especially then to the future, so that we would have epidemiology using perhaps then the orphanet classification of the vascular anomalies. And then we would be ready for the recommendations writing, etc. But I think that at the moment it's a little bit too early. The outcome measures we will follow. We know that it takes time, and that's an international activity where we are parts of that, but it's done at the worldwide level. So we will follow up that work. And the definition of the patient pathways, now that we've seen some very nice layouts, I think we will take that now with the vascular anomaly patient group and try to get it also for the 12 months milestone, so that we can report on that also for our group.
Okay.
And yeah, true. Then we will discuss some of the clinical trials and try to initiate some different types of clinical trials with the caveats that I mentioned in the morning, but trying to have different centers as motors for different types of clinical trials. But
yeah, I think the difficulty in clinical trial is that we need to have different countries with the same trial. So that's a challenge.
So PPL? No.
Oh, pardon, excuse me. PPL she's on the back. Sahar, why are you at the back? You should be in the front.
PPL, primary and pediatric lymphedema. We're a little bit behind because we were set up a little bit later. Certainly I didn't know a lot of the people, so I think we're a little bit behind some of the other working groups, but we're collecting data. We're trying to initially define the patient pathway, and we'll work through each thing as we go. We're sort of identifying areas for guidelines and information, and yeah.
Okay, so collecting guidelines and going forward and discussing cases and taking shape. That's a good aim also. So I think if we want to summarize, is that it? No? Everybody didn't go? EPAG, no. But for the rare disease working groups, first, if we want to summarize, we can say that not everyone is doing everything, but all together we do everything. So that we will be able to meet our what required. Collectively, we will be able to do what we were supposed to do, even if not everybody by himself is doing everything. So that's the aim of the network. So no problem with that.